To our continuing series on global reach. My name is Satish Kutty. I'm the current chair of the British Hip Society Education Committee, and I welcome you to our Global Reach webinar series. Today, we partner with the Indian Arthroplasty Association, who have an extensive experience on treating ankylosing spondylitis and hip replacement in such patients. So we have an excellent lineup of speakers with fantastic experience in this field. So I pass on to Dominic Meek, our president, followed by Ronen Roy, who is the president of the Indian Arthroplasty Association, to say a few words.
Well, just to thank you very much, Satish, and for organising this. This is the second one in the Global Reach webinars. And I'm really looking forward to being educated and learning from my colleagues in India about ankylosing spondylitis. So really that's great, and I shall pass over to them.
Well,
thank you, Dominic. And on behalf of the Indian Arthroplasty Association, I'd like to say it's an honor to be teaming up with you all again for the second webinar. And we've got a galaxy of stars this evening for you, and they'll be discussing ankylosing spondylitis. And as the talks progress, you'll see that we're looking at covering conventional and looking at taking spinopelvic deformities into consideration, and finally the application of robotics. So we'll be looking forward to an exciting evening, and I hand it over to the moderator to take it forward.
Thank you, Ronen. Thank you, Dominic. I now pass on to Mrinal Sharma, who is my co-moderator, and he's going to introduce the speakers and the various talks. Please keep your questions coming through the chat box. We will take them at the end, and we hope to have an excellent discussion on this matter as we complete the talks. Mrinal, over to you.
Thank you, Satish, and thank you, British Hip Arthroplasty Association, for giving us this opportunity to collaborate with you all. We have tried to cover ankylosing spondylitis in three aspects: the conventional way of doing total hip arthroplasty, a total hip arthroplasty in ankylosing spondylitis using the spinopelvic parameters, and how you can use them well with the robotics. So we have a galaxy of presenters here. Our past president, Dr. Rajeev Sharma, past president of IA, is going to give us the lecture on total hip arthroplasty in ankylosing spondylitis using the conventional methods. Then we'll have Dr. Vijay Bose, who is going to present on total hip arthroplasty in ankylosing spondylitis using spinopelvic parameters and how he adjusts for them during his surgery. And the third talk is going to be none other than Adarsh, who is doing a lot of robotic hips, and he's going to speak on ankylosing spondylitis using the robotic with covering the pelvic spinopelvic parameters into consideration. So over to you, Dr. Rajeev, for the first presentation.
Thank you, Mrinal. Thank you, British Hip Society, Dominic and Satish. Thanks, Ronen, for giving this opportunity. And my mandate today is to speak on total hip arthroplasty in ankylosing spondylitis, the conventional way. Indications for the total hip arthroplasty in ankylosing spondylitis, as has been widely accepted, is that not just for the pain relief, but also for the restriction of the day-to-day activities, even in the absence of pain. There are multiple challenges in these cases, which differ from case to case. A number of joints involved, both hips, or having the fibrous ankylosis of both the knees, the bony fusion, or the fibrous ankylosis, what kind of anesthesia to be given, what position on the table, surgical approach, which one to be chosen, and the assessment of the pelvic tilt and spinal mobility. The planning issues are whether to do it simultaneously on both the hips or in stages, whether the stages should be staged at 3 days or at 3 months. If the hip and knee both are involved on both the side, both the extremities, then one side, hip and knee to be done, and the next extremity can be done at a gap of 3 days or 3 months, and that we will be discussing, I'm sure, that in the panel discussion today. The cemented or the cementless implants to be used, it has been widely written in the literature, accepted that cementless implants are also good to use in ankylosing spondylitis cases. What surgical approach to be chosen? A standard posterior approach, or the dual approach for difficult cases, or the transtrochanteric approach, or the direct lateral or anterolateral approach. The release of the soft tissues is always a useful technique, iliopsoas and subcutaneous adductor tenotomies. It helps in checking the position of the acetabular and the femoral components in a freely mobile hip. And also, it improves the post-operative range of motion. The surgery is very simple to be done before the total hip arthroplasty incision is given. And then depending upon if the patient is having a flexion deformity, then the anterior release. If the adduction deformity, then the adductor tenotomy. Standard posterior approach in most of my cases, the ideal location of the incision lies over the mid-axis of the femur laterally and curves posteriorly by approximately 20 degrees at the tip of the trochanter. Usually in these fused hips, it is not easy to reach the hip, and one has to be very careful, especially for the injury to the sciatic nerve. But with the care and careful dissection, it is not very difficult to see. The dual approach is used for cases which are having the difficult exposure, especially for the cases where you have a hip ankylosis in abduction and in external rotation. Heterotopic bone to be removed first. The neck is cut in situ. In fused hips, segmental resection is better. Care must be taken to avoid too proximal or too distal a cut. Soft tissue releases to be done. Capsular release, and one has to be careful that when you are doing the capsular release, the care to avoid injury to the artery is very important. Start reaming the remaining femoral head. Assessment of orientation of the reaming depending upon the transacetabular ligament and the assessment of the pelvic tilt while reaming is important. Care points are injury to the artery, avoid over-reaming, paraoperative fractures, impingement, and malorientation. The neck is cut in situ in fused hips, especially the bony ankylosis. Segmental resection is better if you have the sufficient length of the bone of the neck visible. Care must be taken to avoid too proximal or distal cut. One must prevent the injury to the trochanter and the posterior acetabular wall. The use of the saw is useful, but one has to be careful that the saw is the use for the initial cutting, and then after the completion of the osteotomy with the osteotomes. Adequate exposure is very important to decrease the injury to the atrophied and weakened abductors. Sometimes because of the too weak abductor, advancement to improve the stability is important in some cases. Reaming of the acetabulum should be done without removing the femoral head. One can just use the counter rotation technique, avoid over-reaming of the osteoporotic acetabulum. The depth measurement at the bottom is a very useful tool. And usually if you leave about 8 to 10 millimeter of the medial wall, I think it's a good idea to avoid over-reaming of the acetabulum. Original joint plane located by the foveal soft tissue and incomplete gray ossifying cartilage. Even in the bony ankylosis, usually it is not too difficult to find out the true floor of the acetabulum. Importance of adequate exposure is not much to be explained. It has to be, you have to have a 360-degree view of the acetabulum to have a good fixation. Use the one pin superiorly, one Holmes retractor at the anterior-superior wall of the acetabulum, one Holmes retractor at the teardrop, and one posterior retractor. And usually these 4 things are enough to give you a very good exposure to the cup. Training of the osteophytes is important, especially the anterior osteophytes, and using the high-speed burr is a very useful technique. Use the high-speed burr, keep using the saline over it to avoid the heat injury, and then use the curved osteotomes to remove the osteophytes, because sometimes in these ankylosing spondylitis cases, there are huge amount of large osteophytes which are visible and which have to be removed and managed in time. And the osteophyte can be used and then use the nibbler to take out the excess osteophytes. Posterior osteophytes can be left in place if needed. The position of the cup, anteversion of the cup is confirmed with the indication of the transverse acetabular ligament and the long axis of the body. And spinopelvic mobility and acetabular cup placement we will be discussing by Vijay and then after by Adarsh. The femoral component, one must maintain the maximum neck length and the offset, because the lengthening of the limb that had been shortened by the original disease and by the fusion procedure. Better mechanical advantage for the weak abductors, additional stability of reduction under the maximum muscle tension is much more useful. Uncemented stem is preferable in my hands, modular component for restoring the hip mechanics and improving the stability. While preparing the proximal femur, one has to be careful to prevent the fracture of the trochanter. One must be careful to avoid the injury to the abductors, which are already weak in all these cases, and watch for a crack in the proximal femur. And gradually increasing the size of the broach, one has to be careful that the final broach should be having the good fixation if you're using a cementless implant, and you must see by the toggling rotational movements of the broach that the broach is stable in the medullary canal, and there is no rotational movement possible in these cases. Check for soft tissue tension, impingement, stability, and combined antiversion. In all other cases is very important. One example where you have the bamboo spine, hips ankylose in extension, both hips, sacroiliac joints and spine are fused, and hips are having the spontaneous bony fusion in extension. We can see that the X-rays, the anesthesia used in this patient was general, position on the table lateral, surgical approach was posterior, and in this patient the whole spine was fused. That's what we can see here. Post-operative, on the left hip we use the anatomical head, the delta motion implant. On the right side, we use the ceramic on poly implant. Cementless, the result at 3 months and at 6 months. Having the good function, patient was still trying to develop the abductor strength, and we see that the patient is having an excellent function at the period of 6 months. And the same patient at 9 years, having regained almost a good strength of the abductors and all the muscles around the hip joint. Another patient where you have the bilateral hip involvement, stiff spine, fibrous ankylosis, but the correctable position of the pelvis, that's what you see in two pelvic X-rays. Here it was very interesting to find where we went for this surgery for the patient had intractable back pain. And the tuberculosis in these patients, ankylosing spondylitis, is not a uncommon situation. One has to be careful, and we realized that this patient had the tuberculosis at the dorsal 11 and 12 vertebrae. The patient was given a treatment of 6 months by antitubercular treatments, and then after the simultaneous bilateral total hip was done. That's for this patient at 1 year, and antitubercular treatment was continued for a period of 18 months. At 2 years post-operative, the cox spine was healed completely, and patient was still kept on TNF alpha blockers for the intractable back pain, and which is found to be very useful in this particular patient. Another patient, bilateral hip involved, some hip movement preserved, spine not fused. We can see that there is some amount of function is possible in the hip joints, both the hip joints. It results at 2.5 months, at 6 years, having the excellent function of both the hips. Another patient, bilateral hip involvement, fibrous ankylosed hips, spine fused in flexion, result by cementless total hip arthroplasty on both the sides, result at 5 years. A very unusual situation. I've kept it specifically because this position is almost very, very rare, where the bony fusion was done in 90-degree abduction and fusion in 60 degrees of external rotation, giving a very difficult situation to operate. The exposure was done with a dual approach with trochanteric osteotomy, and that's what the patient's final result was. The problems in these patients are iatrogenic fracture, over-rim acetabulum, insufficient bone contact for cup, component loosening, heterotopic ossification, for which the prophylaxis has to be given by indomethacin and sometimes the radiotherapy, impingement, and the vascular injury should not be forgotten at all. It has been shown by various literatures that the complication rate in ankylosing spondylitis is much more as compared to the control. Methotrexate and sulfasalazine helps in peripheral arthritis, but not in the spinal arthritis. The first line of treatment is NSAIDs, and if they fail, TNF alpha blockers, which are the newer medicines, are very useful. And if the anti-TNF fail, the IL-17 inhibitors are useful, and which are available in India these days. One patient of bilateral hip, sacroiliac joints, spine fused, a spontaneous fusion in flexion. Patient was walking almost on the hands for a long time. This patient was operated long back, having the surgery of both the hips first and then both the knees. This kept here specifically to show that the over-reaming of the acetabulum on the right side was a problem, and one has to be careful in such situations. That's the patient at a year's follow-up, and then after at 7-year follow-up, the patient is still kept closely in the follow-up. Another patient with this failed cemented cup came for the reason acetabular loosening in 6 years, and this patient was used with the trochanteric osteotomy and a hybrid total hip arthroplasty implant. That's the patients at the 5-year post-revision surgery. Another patient where the cup loosening in 3 years only, the 2005 operated failed cemented cup, leaving a large medial defect. And in this patient, in 2005, the octopus cage was used with the autoiliac allografts. Bone substitutes were used simultaneously to reconstruct the acetabulum. And that's what the surgical pictures, and that's the result of the patient. And the 7-year follow-up of the same patient. We must remember that the arterial injury would be a major issue, and it needs to be avoided at all costs. I'll conclude saying that careful preoperative planning is important. Ensure availability of suitable implants for operative fractures to be avoided.
Thank you, Dr. Rajeev, for an excellent presentation. We'll take the questions later, Satish. Yeah.
Yes, so, yes, that's correct. At the end.
Let me invite Dr. Vijay Bose. He's a big name in Indian hip arthroplasty, and he has many implants designs to his name. Invite him for his presentation on total hip arthroplasty in Angspond using the spinopelvic parameters and how he reproduces it.
Thanks, Mrinal. Thanks to Satish and Dominic and the British Hip Society for inviting me. It's truly a pleasure for me to participate in this webinar. I'll share my screen. Right. Okay. Right. Okay. So my task today is to show you how we use the spinopelvic parameters into consideration when we operate on Angspond. Very common pathology next to avian. The most common pathology that we encounter today here in this part of the world is Angspond. So I'll be talking a bit about the Naviswiss, which is the hip navigation system that we are using currently, and Adarsh should be talking about the robotics. But the thing is, the real point is not to make a point that we need expensive technology, but what we learn from this technology and how we apply it in day-to-day practice. That's what really the core is all about. So this patient, you can see, has got bilateral fused hips. He's got a very gross spinal deformity as well. So the question is what to do. So don't worry, I'm not going to, bore you with all these complex cases. So today I'm going to just stick to the very basics of how we do it so that everyone can understand how we apply these spinopelvic parameters. So spinopelvic parameters is an esoteric science, and that, all these conferences and webinars we talk hours and hours on this particular topic, which is currently the hot favorite. But when you ask any surgeon how do they apply, they just say in any Angspond, I would just give a little bit of antiversion. That's the final message. That means they have not understood what's happening. And it's only the faculty that keeps talking about this spinopelvic parameters. So today we want to sort of simplify the whole thing so that everyone can apply that. So that would be my task today. Now, also I'd like to say that this concept of just giving a little bit less antiversion is a very flawed concept. And some patients, in ankylosing spondylitis, you may actually have to increase the antiversion. So please don't go by the opinion that in Angspond, you just give a little bit of less antiversion and everything will be fine. Certainly not. So the problem really is today is we have looked only at AP X-rays for so long. Imagine a knee arthritis, and if we ask someone to comment only on the AP X-rays, we won't comment on that because we need to see the lateral view. Similarly, hips, we must learn to look at the lateral views. Once you start looking at the lateral views, then it sort of becomes very apparent of what's happening. So if you don't look at the lateral view, that's where all the problem comes from. So we're very familiar with AP views. We're very, very unfamiliar with. So the first thing about spinopelvic parameters, we must do sort of routinely these lateral views of the head and the pelvis, and then everything will fall into place. Now, defining coronal and sagittal deformities, we're all very familiar with pelvic obliquity. Everyone can recognize that. However, we are not very confident in recognizing pelvic tilt, which is nothing but the same kind of deformity that's occurring in the other plane, which is now the sagittal plane. And the pelvis moves one way or the other. And it is just like the obliquity in the coronal plane, the tilt is in the sagittal plane. So that's all there is to the deformities. Now, taking that point further, when you talk about component placement, now if you have a patient with a fixed pelvic obliquity, there are two axes that we all know. One, you can either the trans iliac crest axis or the trans teardrop axis will give you the actual tilt when you compare it to when you angle between that and the horizontal. So you can't put the cup either anatomically, in which case you'll find that you will put it with reference to the trans iliac crest line. Whereas if you want to put in a functional position, you would do it based on the horizontal axis. So that everyone knows, and that's very simple for us to follow. Exactly the same thing that we are going to do in the other plane as well now. So here we have so this is the spinal parameters as far as pelvic obliquity goes. It's very simple. And the first thing that we want to establish in pelvic obliquity is whether this obliquity is going to be fixed or not. For that, we need to get lateral bending films, right and lateral spinal bending films, know it's fixed or not. And if it is fixed, then we are going to go by the horizontal axis to be as a reference point because it's not going to correct post-op. However, if it is mobile, then we are going to use an anatomical axis, which will be the inter-teardrop axis, and that will give us a functional plane. So the same thing we're going to apply now with the pelvic tilt. So pelvic tilt is nothing but a line joining from the midpoint of the sacrum to the midpoint of the hip joint or the socket or the femoral head. So that tells you what is the tilt in the sagittal plane. Now, just like the obliquity, it's the horizontal relation to the horizontal plane. The pelvic tilt is always in relation to the vertical plane. So that's what really the tilt is all about. There's one more plane that we must know about. That is the anterior pelvic plane, which is the line joining the anterior spine with the pubic crest. And that will give you the anatomical plane. Whereas your vertical line would be the functional plane. So it's when you start comparing it to obliquity, things really fall into place. So cup placement relation to APP would be anatomical placement. Cup placement relation to vertical axis would be the functional placement. And so those are the two important concepts that we need to understand. Now, how do we know just like the pelvic obliquity, we have to establish whether this spinal deformity is fixed or mobile. For that, we need to get sitting and standing films. And that we make out whether it is fixed or not. So if it is fixed, then we would go with the functional plane as regards to the sagittal axis. And if it is mobile, that means it's going to correct post-op, then you would use the anatomical plane or relation to the APP. So those are the basics. Now, there are hundreds of spinopelvic parameters, but three are most commonly talked about in all conferences. One is the pelvic incidence, pelvic tilt, and pelvic slope. Now, for all practical purposes, you can sort of disregard the pelvic incidence. Pelvic incidence is important only for spinal surgeons. Depending on whether you have a high pelvic incidence or a low pelvic incidence, the spinal surgeon will decide whether whenever they're doing a spinal fusion, whether they have to fuse it in lordosis or in kyphosis. So as hip surgeon, as British Hip Society, that webinar today, we can, for all practical purposes, disregard pelvic incidence. That leaves only two parameters, the pelvic tilt and the second. We already covered pelvic tilt, and we'll cover a little bit about sacral slope. Sacral slope, as we say, it is the S1, the plane of the S1 in relation to the horizontal plane. That's just the sacral slope. Now, when you're standing, the sacral slope is quite large. It's about 50 degrees. And when we sit down, there's a posterior pelvic tilt by which the sacral slope becomes 30 degrees. You can see in this diagram how there's a posterior pelvic tilt, and from standing to sitting, it reduces from 50 to 30 degrees. Now, pelvic tilt we already covered, line joining the midpoint of the sacrum to the midpoint of the hip joint in relation to the vertical that we have. And as from standing to sitting, the pelvis tilts posteriorly, and you can see how the pelvic tilt increases quite significantly from standing to sitting. So from standing, the pelvic tilt is about 10 degrees, sort of an average, and sitting, it's about 25 degrees would be the pelvic tilt, sort of the average. So the important sort of rule of thumb is that the pelvic tilt is a surrogate marker of anteversion. So also you can see these values are very familiar to us, 10 to 25 degrees. Now, here's the first case example. Here's a patient with the pelvic obliquity. We'll deal first. And you can see that quite significant pelvic. We want to make out whether this spine is fixed or not. For that, we knew right and lateral films. And this particular patient, the spinal deformity was quite fixed. Therefore, we need to put this cup in a functional position, and that's what we have done. We're not put anatomically, which would have been very open, because the patient is not going to correct post-op. So we used a functional plane to place this cup for this pelvic obliquity. Now, when it comes to surgical deformities, the first thing to recognize in the AP view is your operator foramen. Dr. Annapareddy has described very well the cat size. So when the cat size is normal, as you can see, we all know how the operator foramen looks normally. That's a normal cat size. That means there's no sagittal abnormality. You don't need to do any special x-rays. However, when the cat size is open, our operator foramen is very elongated superior inferiorly. That means there's a lumbar kyphos, and we may have to give some compensation. The reverse is when you find that the cat size is very closed, or the operator foramen is like split-like or not seen. That means there's an exaggerated lumbar lordosis. So this is the how we recognize that we need to do something more than just putting the cup blindly. So this is a very good picture to show how when you find there's a pelvic tilt, the anteversion changes. So you can see that to your left, see there's a lot of anteversion you can see in the cup. Although the cup is already placed, if the pelvis tilts, you can see how the anteversion changes quite significantly. So it's very easy to understand this diagram how the pelvic tilt would influence anteversion. So we really have to know how it influences. So once we start looking at the lateral views, you can see in this patient from standing to sitting, you can see that if you saw a line that joining the on the socket with relation to the horizontal, you'll find 27 degrees, and sitting it becomes 2 degrees. So you can standing to sitting, you can see it's opening up. This is the lateral view, not the AP view. So measuring the inclination on the lateral view, you can see that is known as anti-inclination. So just like how we would measure the inclination in the AP view, we measure the same thing in a lateral view. It's anti-inclination and is an indicator of the cup anteversion. So we have to know the exact relationship. So which is basically for every 1 degree increase in posterior pelvic tilt, the increase in anteversion is 0.7 to 0.8 degrees. So that's all there is to it. So we have covered all the theory behind that. So from this, we have to answer 3 questions by looking at these parameters. Is the lumbosacral spine fixed or mobile? If fixed, which position is it fixed? If stuck, what compensation to give for in every particular case that you are looking at? When you say compensation in the sagittal plane, what you're really implying is, how am I going to change the combined anteversion for this patient? That's what you're going to cut. And there are 3 ways to do it, which we'll cover. So here's a case example. Here's a patient. You can see he's got ankylosing spondylitis. He's got very stiff hips. And here you can see from standing to sitting 2 films, the lateral hip and spine films. The standing sacral slope is 40. Sitting is 0. And you find that the pelvic tilt is 16 standing, and the pelvic tilt is 54. That means there's a very mobile spine. So although this patient has got ankylosing spondylitis, you must not give any compensation. So some people say it's 10 degrees, some people say it's 15 degrees, but when the change is less than 10 or 15 degrees, only then it's a stiff spine, and only then you have to give compensation. Otherwise, you should not be giving compensation. So in this particular case, no compensation must be given, and you have just put the cup as in any other case, no compensation has been given. Now here's case 2. Here you find that the sacral slope is 38, and standing and sitting is 36. That means hardly any movement. And the pelvic tilt, there's only 2 degree difference between standing and sitting. That means the spine is fixed, and you got to give a compensation for this patient. Now we're going to find out how is this patient, answering question number 2, how is it fixed? Now you can see that these parameters, the patient there, you can find that the sacral slope is on the, as how it'd be sitting. We say it's from 50 to 30. So it's very close to 30. So it's like a sitting parameter. Sacral slope is like a sitting parameter. The pelvic tilt, again, is close to 25. So it's like a sitting parameter. So both the sacral slope and the pelvic tilt are sitting parameters. So therefore, we call this as stuck in sitting. So now we have found out that this patient has got a stiff spine and is stuck in sitting. And therefore, we need to reduce the combined anteversion. The goal in this patient is to reduce the combined anteversion. So how do we go about it? If you can use a simple cell phone and measure the combined anteversion like shown in this diagram. And then you can either change the socket version, you can change the stem version, or you can change both to reduce the combined version. Or if you don't have that ability, then you can use a stem with a versional freedom like a S-ROM or a Cohn-Wagner, and then you'll be able to give a less combined version. Now, this is the navigation system that we use now. You can see that how we are marking the functional pelvic plane. These are these pelvic tags, and we're showing to the navigation system what is going to be the functional pelvic plane. And based on that, you can see that even if you don't have the system, you can draw a line which basically is a plumb line with the patient lateral position. That is the functional pelvic plane. And because we don't have any measurement of the anteversion, you can use a fixed point of inclination and actually measure the anteversion as a length. If I have time, I'll cover this later on. So this is how we now document what is the anteversion in so many millimeters, so that we put a value on whatever that we're doing. So the combined anteversion in this patient has been brought down to 20 degrees based on the spinopelvic parameters. So this functional pelvic plane has been well described, and this is a paper from Germany which describes the lateral decubitus patient position and how you take the functional pelvic plane into account. So here's another example of a patient. You can see again the pelvic parameters are very similar to the previous one. The patient is stuck in sitting, and Rajeev showed a lot of X-rays. They're quite disabled, and once you get the apply the spinopelvic parameters and put your socket in the right position, you get a very functional result. So in conclusion, I'd like to say Ankylosing is very common in Asia. It is second most commonest indication for arthroplasty, hip arthroplasty. Assessment of spinopelvic parameters is absolutely critical. Please don't go under the opinion that for Ankylosing patients, you just reduce the anteversion a little bit and all problems are solved. Certainly not solved. You need to look at and start doing lateral films so that you get an understanding of what's happening in the sagittal plane. Understanding and application of concepts are more important than having access to expensive technology. We have access to robotics, but I always feel that 90-95% of what the robot achieves, you can do with simple, no-cost, gadgets, or in a very simple that everyone has access to, and only the last 5-10% that the robotic or the navigation will add. So all these concepts are important rather than expensive technology. In 2023, we must put a number on all variables, whether hip, knee, or shoulder arthroplasty. We cannot say just increase anteversion a little bit, just decrease the inclination a little bit. I don't think we should accept that anymore. Every parameter in arthroplasty from these days must come with a number. And once you start putting numbers, you become very, very accurate. So that's the thing. Thank you for the opportunity again. Thanks very much.
Thank you, Dr. Vijay. We'll have definitely some interesting questions on your talk. Let's invite Adarsh on his, experience on robotics in Ankylosing. That's going to be interesting, and how he uses the spinopelvic parameters.
Yeah, very good evening to everyone. Let me just put this in a presentation mode. Yeah. So I would like to thank the British Hip Society and the Indian Arthroplasty Association for inviting me here today. I'm following up two beautiful talks by Rajeev sir and Vijay sir, and I've learned so much from both of them. And this is some technology which has come to just help us more. You need to know all the basics, otherwise you're not going to understand the role of robotics in this. So just a brief, as you all know, it's an inflammatory disease that affects the axial skeleton, and hip involvement is very common. Prevalence of hip involvement is 24 to 36%, and it leads to fusion. And in Southeast Asia, the prevalence rate of a fused hip is between 0.18 to 0.54%, which is still quite a big amount. So as mentioned earlier by both the speakers, in healthy individuals, the lumbar spine is flexible in the sagittal plane. The pelvis tilts posteriorly to accommodate the hip flexion when moving from standing to sitting. So in summation, when you sit, the pelvis will tilt posteriorly. That's one thing that you should all just remember. This now with the robot, we can see what happens if the hip moves and the pelvis doesn't. It shows us where the impingement may happen. You can see over here, there's an impingement happening now between this bone and this bone. And this is what happens if the hip keeps on flexing without the pelvis moving at all. So you can see that this bone is impinging over here. So this is a bit of information that we now have with this new technology. So ankylosing spondylitis, we're talking about two different things. Two things may be there in each patient. One is a stiff spine and one is a fused hip. And both these things together will give a technically difficult THR. So we'll be discussing about how the robot helps in both of these technically difficult situations. So as you all, as mentioned by Vijay sir also, the latest discussion point in THR, now all these discussions have become old hat. It's all about the THR and stiff spine. So again, pelvic translation effect from standing to sitting. When you sit, the pelvis tilts posteriorly. That's what's supposed to happen. People with a spinopelvic pathology who undergo THR have an increased risk of dislocation. And recently, the hip spine classification system has come up with a simple and effective way to identify patients at an increased risk of dislocation. It's by Dr. Vijay, and this is the paper. You can all check it out. It's a very good paper, and he has summarized the 4 different types of Spinopelvic Association. So he proposed the hip spine classification in 2021. He categorized patients for total hip arthroplasty based on spinal mobility and the hip range of motion. It's widely used to guide surgery and implant design for THR in patients now. So just a bit summarization of that paper. He said there are two spinal issues that affect the pelvic position in THR, that is spinal deformity and the stiffness, as Vijay sir had alluded to. The flexible spine allows a posterior tilt when transitioning from standing to sitting. But a stiff lumbar spine limits the pelvic tilt adjustment, affecting the hip flexion when sitting. Inadequate component positioning can lead to prosthetic impingement, which leads to dislocation or bony impingement. THRs for patients with spinal stiffness or deformity, it's safe with proper pre-op planning based on this classification. And remember, we're looking for modified anteversion inclination targets. That is called as functional placement. We're not always going to look for 20 degrees of anteversion and 40 degrees of inclination anymore. So just again, the classification depends on these 4 parameters. So first you look at the alignment of the spine. Is it a normal alignment or a spinal deformity? So normal alignment means the pelvic incidence minus lumbar lordosis should be less than 10 degrees. And a spinal deformity means the pelvis incidence minus lumbar lordosis should be more than 10 degrees. Not going to go too much into depth, but if you just remember these calculations. So again, in a normal alignment, you can have a normal mobility of the hip or of the spine or a stiff spine. So the delta SS means the difference between the sacral slope in standing and sitting position. If it's more than 10 degrees, it's normal mobility. So this class is 1A. Normal alignment, normal mobility is 1A. Normal alignment with a stiff spine of a delta less than 10 degrees is 1B. With spinal deformity with a normal mobility is 2A, and stiff spine with a spinal deformity is 2B. This is how he has classified how we do each particular case. With 1A, we have a normal inclination of 40-20. With 1B, we try to increase it a bit, 45 to 25. If you come to the main one, which the one that we see regularly, is stuck in sitting position, as shown by Dr. Vijay sir. Usually they say you reduce, so component target should be less than the native anatomy or inclination. So now we have all these variables: cup size, femur size, height, depth, rotation, anteversion, inclination. All these things have been made easy with the robo. And now even stiff spine has been made easy with the robot. Just a brief workflow. So this is a CT-based robot. It's a CT-based robot. So you can do the preoperative planning. Then you place the landmarks, place the arrays. Then you do something known as a registration of the acetabulum and the femur, where you're corroborating the real-time bone to the CT scan which has been taken. Then the robot also helps in reaming and cup impaction. Finally, the femoral preparation, trial reduction, and you get reduction results as well. This is a brief overlook of the workflow. So implant planning, you can use it for the acetabulum. You can use it for the femoral anteversion and the size as well. And you also can see the preoperative visualization of the post-op X-ray. So now we've moved from 2D manual planning to 3D model-based planning. You can immediately get a 3D reconstruction of each patient's bones, and you get a pre-op limb length assessment as well. You know whether you're 3 millimeters shorter versus the opposite hip and how your offset is decreased compared to the opposite hip. You also get a pre-op visualization of what your implants would look like. Then you can plan the acetabular component placement in the transverse, the sagittal, and the coronal planes. And you can also determine whether you want inclination as 40 degrees and version as 20 degrees. You can also restore the center of rotation. If you see the pink dot over here is the native center of rotation. The green dot is where your cup will be. The center of your cup will be after implantation. This is another view. Now with the Mako 4.0, this is the new upgrade for the software. You have something known as functional hip positioning, where you can adjust your acetabulum and your femur depending on your virtual range of motion, which I'll show you in the next few slides. You can now include your pelvic tilts. This feature allows the user to plan the placement of the cup based on each patient's pelvic tilt or sacral slope. You can either use the sacral slope or the pelvic tilt as your parameters. It allows the user to modify the cup inclination and cup version for that particular patient's pelvic tilts. So this is what it looks like. As you can see, as you know already, that the pelvis will tilt normally, but sometimes in a stiff spine and a stiff hip, it will not. So each person's lateral x-rays are taken in standing and sitting. We calculate the sacral slope with standing and sitting. We enter these values into the robo, both standing and sitting. So it knows how stiff that particular spine is. And then we check our virtual range of motion. And then we determine whether we really want to go ahead with a regular 40-20 or whether we want to change it. Then we go for the femoral component sizing and offset adjustment can be done. So we can even tell us what the femoral anteversion is. So we know the combined anteversion. So it adds together your femoral anteversion and your cup anteversion, gives you what your combined anteversion is or whether you're within your range or not. This is something called as virtual range of motion. Once you've entered your values, you can go through complete range of motion. In sitting position first, it will tell you whether you're going to impinge. In this position of 40, 25, whether you're impinging or not. See 100 degrees of flexion, this person is fine. But once you start internal rotating this patient, he's absolutely okay. Then he starts to impinge at around 40 degrees. What about standing? Standing also the same thing. If you see this patient is in 40, 25 degrees, 40 inclination, 25 anteversion. And once you start external rotating, it starts to impinge over here. So what do we do in this particular situation? We reduce the anteversion and see what happens. And you can see that the impingement goes away. So now you're actually changing your anteversion and inclination as per your sacral slope values. Of course, you get a pre-op visualization of the post-op X-ray. And after the planning, all this planning is done, it also is going to help us in actually executing our reaming. So earlier we had sequential reaming with the manual THR, with incremental reaming followed by trialing of the cup. But now with the robotics, we ream the acetabulum only once and implant the final prosthesis. And this also helps in bone preservation. So this, if you see over here, down here, you can see I'm putting the reamer in, and on the screen, the green part is where we need to remove. We have a conical haptic, so you still have the freedom to move your robotic arm around. And it's going to let me remove only the bone which is required to be removed. And once that's done, it's a single ream. I can implant my cup. So it also tells me how much depth I need to go. If you see over here, I'm banging the cup in, and you see this distance remaining over here. It is going to tell me how much further I need to go in. It says I'm 8 proud, and now I'm 2 proud, and I'm 1 proud. So now I'm in, I don't have to go any further. Otherwise, I may shatter the quadrilateral plate. It also lets me check what my final values are. Let's say this one was planned as 40-20. We got a 39-22. It gives us all this information as well. So let's go through a case. It's an ankylosing spondylitis case where we had a stem version of 20 degrees. Because it is quite an anteverted stem, when we went through our range of motion, it showed there was a lot of impingement on a regular 40-20 on a standing. So when we tried to extend and external rotate our hip, it was impinging on the cup. So what we did was reduced our anteversion 12 degrees. We usually, in a conventional case, we don't tend to put our anteversion in 12. We get very panicky about that. But here we managed to bring it down to 12 degrees and reduce the impingement. Went through a good range of motion. Our combined anteversion was still within our range. So we went ahead and we implanted it. We got 41-11 as opposed to 40-12 planned. And we got a great hip with a very stable hip. Another patient, if you see this pre-op X-ray, he has a few sacroiliac joints, bilateral arthritic of hips, inflammatory arthritis. If you see the delta in standing and sitting is only 6.9 degrees. Between standing and sitting, there's only a difference of 6.9. That means it is a stiff spine. And it's less than 30 in both standing and sitting. So this means it is stiff and stuck in sitting. So this is type 2B. So in general, we normally say that in type 2B, we have to reduce the anteversion of the cup. That's what we have learned in all the previous slides. But let's look at the other parameters over here. So it has showed us, so we've done the planning. We've got the right size of the cup. We've initially put as a 40-20. But then, and if you see in this 40-20, there's no impingement in standing and sitting position. But what happened is when we saw the femoral anteversion, it was a retroverted femur. So it is a paradox. What do we do here? Do we increase our anteversion of the cup or do we reduce it because of the 2B stuck sitting? So we went through, we entered the values of the sacral slope, standing and sitting. Then we found that the robot is telling us that we're impinging at 40-20. So we actually increased the anteversion of the cup. If you see over here, we increased to 25 and we got rid of the impingement and we got a beautiful hip, a nice steady hip, stable hip. We did put in a dual mobility just to be safe. That's always a safe bet. And we got a great hip. So now let's go to the next part of the dilemma, which is the fused hip. So normally a CT-based robot has to segment all the CT scan films and they come together and create a 3D model of that particular patient. Then the segmentation is done on the femur. And again, the same segmentation is repeated on the acetabulum. And that's when we go ahead with the planning and the execution. But when you have a fused hip, there's a bit of a change here. What we do is we segment the whole the femur as well as the pelvis together. So as an en masse, as an en bloc segmentation. So the CT scans of the pelvis are performed as per the protocol, but segmentation of the pelvis and the proximal femur should be performed en bloc together. And the landmarks which are placed are adjusted in the pre-plan such that the initial 3 acetabular alignment points are now outside the acetabulum. Usually the registration of the acetabulum is within the acetabulum, but here we're trying to register it without dislocating it. So what we do is we register outside as a single mass of bone. And after we do that, then we do a regular planning of the cup and the stem as we were earlier. We can also do an in situ neck cut, where we can just use the probe to tell us where the neck cut should be. I'll just show you a quick video of that as well. This is my case we just did last week, where it's a stiff hip. We put in the trochanteric array. We use the probe and it's going to guide us. If you see the screen up here, it tells me where my line is. I put my probe there and I use a cautery to mark it. The same thing down here, use my cautery to mark that place, join them together, and I take a cut, which is an in situ cut. Okay, and then you take the cut as we normally would. Then you go ahead with the remaining rest of the case. So just quickly go through this case. This is a right ankylosed hip. Pre-op CT shows a completely fused hip. We do a pre-op planning for the components, the acetabulum, and we do an extra-articular registration of the points. Then en-bloc reaming guidance. So then we use the cut, as I mentioned earlier, you do the neck cut in situ and use the robot with this. I've taken this case from Dr. Ashish Singh, and he has sent me this graciously across this case. So you can see, though it looks very odd on this picture down here, we're able to ream out the head within the cup without having to take out the head. And this is what it looks like. So reamed away the head in situ. You get a beautiful bed over there. We can again check. You get inclination of 41 and 20 anteversion and a great post-op X-ray as well. This is our case. Again, ankylosed left hip. We did all our planning on the acetabulum. We got a pre-op visualization of the post-op X-ray. And at the end, after all the planning, we managed to get a nice stable hip as well. We're doing a study. We're evaluating the spinopelvic parameters based on the sacral slope in Indian patients. And we're taking all our patients and calculating our sacral slope values. And we found that presently out of 72 patients, 1A is 40, 1B is 10 patients, 2A is 16, and 2B is 6. We do have quite an increasing number of stuck in sitting position patients as well. Thank you so much.
Thank you, Adarsh, for an in-depth review of robotics in Ankh-Spond, especially those difficult cases which you're doing with the robotics and the ones which cannot be dislocated at all. So that's a new insight into this concept. Satish, we'll have some questions.
Yes, we do have. I think some have been already answered by Rajeev. But the question to all is that the suggestion that uncemented stems, can we use cemented stems or do they fail prematurely? We can start off with, since Rajeev has already answered, let's go to Vijay.
Yeah, thanks. Well, I think it's just your philosophy. If you're, I don't think it fails prematurely. And Ankh-Spond, if you are happy cementing it, I don't see a problem. But generally in India, we tend to do very young patients. We don't do the primary osteoarthritis. So we tend to go stick to non-cemented stems as a philosophy. And then we follow the same into Ankh-Spond. But having said that, there are some Ankh-Spond with very like Dorsey canals where I wouldn't hesitate to cement it. But I think Ankh-Spond by itself doesn't change the choice of stem. Whatever is your philosophy in young patients, I think just follow the same.
Okay.
Thank you. And to Adarsh?
Yes, I agree with Vijay, sir. Again, most of our Ankh-Spond patients are quite young, at least less than 35 or less than 40 for sure. So we want that to last longer. So we don't have much experience using cemented in these cases. 99% of the time it's uncemented.
Okay, thank you. To follow up on that, especially when you talked about combined anteversion, you wanted to increase anteversion in the femoral side or changes the version that's been suggested. But you're using an ML taper stem. How do you navigate that issue? Because you struggle because you have to go by a particular landmark. You can't change the version in an ML taper type design unless you're using an SROM or a Wagner cone type of stem.
You're asking me, sir?
Yes.
Yeah. So we are not changing the stem as per what we want. We are hitting in the stem as per the anatomy of that particular patient. And then we're just measuring the antiversion that it's giving us. It's giving us an idea of what that native antiversion is. So we are not changing the antiversion there. So according to that, we're changing the antiversion in the cup. It's the other way around, actually.
Okay.
So let me add to that. So the striker stem maybe is a blade stem, so maybe a little bit of a problem. But other non-cylinder stem like the Korai, for example, the Polar, for example, you do have room to change it about 10 degrees. Now 10 degrees doesn't seem a lot, but the combined antiversion is 30 to 35 degrees. So it's 33% of the total version there. The 10 degrees is all that we are interested in here. So most of the uncylinder stems would give you a leeway of changing about 10 degrees. And also depending on where you want to start. So my tip would be, we'll assess what is the native femoral version before we, as soon as we do the neck cut. And then the starting point on the trochanteric region, we'd either take it posterior or anterior, depending on whether we want to increase or decrease the stem antiversion as the case dictates.
So like even that case which I showed where the femoral antiversion is 20, that was the native version. It is quite antiverted. So I was just showing that we can measure the antiversion by using the robotic technology and then adjust in the cup if we need to.
I have a question to all the three panelists. So how do you compensate for the spinopelvic core, parameters without technology? So you're using robotics, Dr. Vijay is using Naviswiss, Dr. Rajeev is doing it by eyeballing probably. But I think if you are compensating something and you're calculating parameters and the degree of antiversion is being added, it cannot be done without use of technology. So do you advocate that Ankylosing patients should always have some benefit of any kind of technology intraoperatively? What's your take on this, Dr. Rajeev?
My feeling is that not necessarily that the technology will help you. I think experience and in the surgery for a complex case like ankylosing spondylitis, you have several issues. It is not just the inclination and the of the cup. Several issues: how you address the soft tissues, how you address the how you take care of the gluteus, how you avoid the fractures, how you have the exposure, the proper exposure of the cup. And having said that, if you have everything available, then probably what is right. What Vijay has also explained very well, that it is not necessarily that you have to have a robotic assistance. It is also sometimes the simple understanding of the spinopelvic mobility and the relationship with the changing the antiversion or the abduction of the cup. I think that is what is more important. May I ask Satish that you asked about the cemented and uncemented cups, and I know that you guys are using mostly the cemented stems. So what is your preference and what is your say on this? Would you prefer a cemented or the cementless stem in your setup?
It's again an individual philosophy. So in very young patients, I tend to go more uncemented. I think Dominic would wage in and say he probably more use cemented stems. So Dominic, you want to say something about that?
I think you're on mute, Dr. Dominic.
Well, I think a lot of the philosophy in the UK has been for the hybrid hip replacement, and people are used to cementing. It has the versatility and you can control the version, the depth and the offset a little bit more easily, perhaps in the cementless ones. We quite like the fact there's antibiotic in the cement as well. So I think both used by the individual who's happy using them will know the nuances of that individual fixation, and they'll be able to compensate for it. And as you say, some cementless stems do give you a little bit more wiggle room on setting the antiversion, although particularly some of the collared ones may be something that people are looking at as well, just in terms of interruptive fractures as well. But certainly for the UK, majority of people would tend to use a cemented stem, and I think both have good long-term results in inflammatory arthropathy. So I think they're reasonable for either to be used.
Well, I have a question for Adarsh and Vijay. I mean, when you're aiming for a functional placement,
yes, sir.
Does TAL become a secondary marker then? I mean, you're not really worried about TAL. Is that correct?
Yeah,
Yes,
go on, Adarsh. Yeah.
Sorry. So we just keep joking that the TAL has lost its importance. No, not really though, because you should always have it for future surgeries and all. But we do have a look at the TAL as well always. In fact, we're doing a study where while we're doing a robotic case, we're using our probe to check what the antiversion of the TAL is as well. I mean, what antiversion the native cup is in. So just so that we have an idea before we do our planning. So though the numbers are telling us that, okay, this is a good functional placement, we still do have a look at the TAL to make sure that we're not going too outside the native anatomy.
The other question that I have is for all three of you.
Ronen, can I just add here? So as I explained in my talk, if you have to first find out in Angspon, it's specific to Angspon, if the spine is fixed, then you must not go by the TAL. That's the whole point of this webinar.
Right.
You must not go by the TAL. But if you have a mobile spine, that means that the spinal deformity is secondary to a hip deformity and is going to correct post-op, then you must go anatomically. The TAL is a very good anatomical placement, one of the tools. Beverland has described that. But if you find the spine is fixed, and that's the whole idea of spinopelvic parameters, if you work out that the spine is fixed, then you must not go anatomically. That's where the mistakes come from.
I think that's probably one of the most important take-home messages from this webinar, I think.
Ronen, Vijay, will you agree with me that even if you use the technology or you decide depending upon the spinopelvic mobility or the stiff spine, that what kind of inclination you have decided to increase or reduce, the TAL will help you to understand. One is the technology, but a counter check with the TAL. That will also tell you that not necessarily that you have to keep it parallel to the TAL.
Definitely,
but also if you are changing the inclination, the TAL will be an advantage that you are reducing the inclination or increasing the inclination or antiversion.
Yes, the TAL is the measure of your anatomical placement, just like pelvic obliquity you take. So whether you want to go anatomically or you want to go functionally, you got to decide what is based on your spinopelvic parameters. And yes, and then I'd go as far as to say you must not place it based on it. TAL is useful in that sense that if you are parallel to the TAL, you're doing some mistake there. So you need to give some correction. You need to give some compensation.
As a matter of interest, I'd like to ask all the panelists, does anyone use radiotherapy or is everyone using indomethacin?
Yeah,
Dominic?
If they've got previous history of heterotopic, I would tend to use radiotherapy, but I think just non-steroidals for standard inflammatory arthropathy like ankylosing spondylitis.
What about you, Satish?
Yeah, same here. If there's a previous history, I just go with indomethacin. I don't use radiotherapy. And if there's a history of inflammatory arthropathy, then I would go with indomethacin.
Rajeev?
I use indomethacin only. No radiotherapy.
Adarsh?
Same here. So indomethacin only. We haven't had any cases where we sent
Mrinal?
Indomethacin.
And Vijay?
No radiotherapy, but any NSAID is fine. It's not necessary, has to be indomethacin.
So I have another question to the panelists as well as our co-moderators. What is your threshold for using a dual approach in Angspon cases? Where will you go only with your conventional posterior approach? Where would you choose going for an interior or a harding approach? And when would you choose a dual approach for such cases? Dr. Vijay, let's start with you.
Yeah, so we used to use a dual approach, especially when you have a very stiff hip, a fused hip in external rotation, and then you find that you don't have access to do your neck osteotomy. And that is classically what we used to do earlier on. But then we developed this technique of doing this posterior trochanter reduction osteotomy. So we see the trochanter, the posterior 1/5 doesn't have any muscular attachments. And once you take that non-muscular portion of the trochanter off, then you get very good access to the neck. And once we started doing that, we found almost I would say, that we don't have any more necessary to go anterior as well. But if need be, I wouldn't hesitate to go anterior to the gluteus medius. So that's the dual approach.
So what about hip fixed in external rotation and abduction? You still go with posterior approach?
Yes. I mean, as I said, so if you're not able to do that, we'll do a posterior approach, go anterior, do a neck osteotomy or a release, come back and do the... so in a complex case, you must, all your, your steps must be very familiar. So you're a posterior surgeon, and the most complex case, you don't go and do some different approach. That's a very wrong thing to do. So you need to come back to very familiar territory. That's very important, I think.
Agree. Dr. Rajeev?
as I have shown, that the dual approach is for all those patients where the fusion is an external rotation, because there the accessing the neck posteriorly is difficult. So at least the neck cut should be done by the dual approach using the anterior part of the dual approach. And in very complex cases, I try to do the trochanteric osteotomy because that helps me in two things. One is that it is giving me the good view of the surgical side, and also that you can advance the trochanter to increase the strength of the abductors.
Dr. Dominic, you which approach would you prefer?
I would try and do the posterior approach. It's
Satish, yours?
Same here. I'd stick to what I am very familiar with. So I would go with the posterior approach. And our experience is quite limited. We don't see such deformities. So it's very, very rarely that we come across such severe deformities.
Okay. And what is the threshold of using a dual mobility? And all of you, when would you switch on to a dual mobility? You've approached from both the approaches. You find the soft tissue is not good enough, or your inclination is not good. When would you switch to a dual mobility intraoperatively? Like Adarsh used robotics and still used a dual mobility.
Yeah, that particular case, yes. I had a double safety.
Yeah. Dr. Vijay, you were saying something.
Yeah. So I think my algorithm is very, very simple. So when I find that I'm able to give adequate compensation, but when we say, suppose we want to say, reduce the anteversion of the cup, at the same time, we don't want to have the anterior edge overhanging. You see, that would cause Ehlers impingement and things like that. So you are constrained, although we say, in principle, you can do that. To an extent, you can do that. But then when you cannot, or you find that the compensation you need, there's also something known as, which I wanted to cover, but I didn't have time for that yet. So your zone of compatibility. For example, you want to reduce the version significantly. You cannot bring it zero, for example, on the established side or on the femoral side. That'd be disaster. So there's a zone of compatibility. So when you find that all these things don't work out within the narrow zone that you've got, then your bailout option is a dual mobility.
For me, Mrinal, it is the dual mobility is a very limited option. Only in cases where you are reducing the anteversion significantly. When you have a possibility of dislocation significant, otherwise, most of the cases probably the normal cup is good enough for me.
I guess if the cup size is much lower, if the head size is ending up to be much like less than 30 to 28 head, then I would probably just to reduce the risk of dislocation, go for a dual mobility in an Ankylosing spondylitis.
Mrinal, can I just take away a point of this webinar? As Ronen said, this expensive technology is one thing, but I think the era that we are living in, it's time to put numbers on anything. It could be as simple as using a goniometer, using a ruler, but whatever parameter that you're using, whether X-ray, you need to put numbers on it. I don't think from now on we can say I reduce the anteversion a little bit. So simple things like a digital inclinometer, a ruler, goniometer, things like that. So whatever you're doing, you must put a value. Once you start putting values, you become very, very accurate, very close to technology. The problem that we had earlier on is we were not putting values. Once you may be accurate, maybe you need to, calibrate that, whatever it is. But once you start putting numbers, you become very, very, very accurate.
Yeah, I totally agree with you, Dr. Vijay. But at the same time, we all must understand that the soft tissue sleeve has not been answered with all these technologies. So we need to take care of a good soft tissue sleeve as well.
Vijay, you showed the picture where you had drawn a line and you were measuring the distance. How do you calculate the angles from those distances?
That's right, yeah. So basically, the digital inclinometer gives you the inclination, so no problem at all. Yeah. It's as good as the Navi-Swiss. So I have no problems with that. I have, calibrated with the Navi-Swiss. Now, unfortunately, we don't have any digital instrument that will give you the version. So you got to put your trial cup inside, and then now you're trying to see what is the angle between that angle of your cup and your functional pelvic plane, which you have drawn. It's the same thing that Navi-Swiss uses as well. You draw a plumb line of the spine, thoracic spine, plumb line it is, okay? Now, to fix that point from which you want to measure, you use a digital inclinometer to make sure whatever angle of inclination of the cup is fixed. For example, say we're shooting for, say, 35 degrees, okay? So, wherever the perpendicular to your functional pelvic plane meets your trial handle, at 35 degrees. So for all patients, it becomes constant. So you know that you got a numerical value. It may be 5 centimeters, 6 centimeters, whatever it is. But that's a measure of your antiversion. So we have reduced the antiversion to this plane. So once you start doing it and start measuring, then you know even in a normal cases, this guy has got tremendous antiversion. This guy has got less antiversion. And once you get that concept, you're really refining your technique. Did I make that clear, Satish? Did I make?
Yes, you did. Yes, you did. So is it too simplistic to say that in stuck standing, you increase the antiversion, and you're stuck sitting, you reduce the antiversion?
As a general guideline, yes. But the question is how much you want to, that again, you need to work out how much you want to. But certainly the take home point is if you do the wrong thing, for example, if it is stuck sitting and for whatever reason, the femur had then increased the combined antiversion, that's going to be a disaster for sure. But if you get exactly accurate, probably you'll escape. But if you err on the wrong side, that's really going to cause you problems.
Thank you. To any final words, because I think we've gone just over the hour, and it's been a very exciting discussion on what's been a very important topic. Start off with Dominic.
No, I just have to say I've had a fantastic time there. I've really enjoyed listening to all these presentations, and I think actually for once I understand spinopelvic.
Yeah. Ronen?
Well, I thought it was great as usual, and I just hope we can keep this up and look forward to collaborating again in the future.
Yes, thank you. Mrinal?
Yeah, I think, Dr. Rajeev, you want to say something?
No, after you.
Okay. So I think we've been to the point. Everyone has given great presentations and used everything, whatever is available in the market, and common sense also to get the hips right in position and the accuracy for Ang-Spond patients. And I think if we have technology, we should use it, and we should use it with taking care of the soft tissue sleeve as well. So there might be patients where probably just the eyeballing might work, but those maybe 2% where we can give them better results using technology, it must be used. That is what I would say.
Thank you. Rajeev?
I wanted to say that to our young surgeons who are here and listening to us, that what is very important is that the soft tissue sleeve, as Mrinal has talked about, the exposure, the various other surgical points which are very important should be the main focus of the surgical aspect. And also for that limited number of patients where there is a stuck standing or a stuck sitting position, probably that understanding should help you. As Vijay has rightly said, that at least you will not err on the wrong side. Like doing the wrong inclination in a stuck sitting is probably a bigger option, bigger problem, and that can be avoided. But the basic surgical principles are very important. Thanks so much.
Thank you. Vijay?
Yeah, pleasure interacting with all you folks. I learned a lot as well. So I think we have some key take-home points, and I hope that there's no more an esoteric science, this spinopelvic parameters, and everybody starts using it in their day-to-day practice. Thanks.
Thank you. Adarsh?
Yes, sir. Thank you. Thank you so much for the opportunity today. And I absolutely agree with what Dr. Rajeev sir has said. The robotics and the navigation and all these things help us, but it can definitely be done without it with a very good feel. And that has to be learned first before we even try to think of adopting robotics and technology. Because unless you know the basics, it's really difficult to implement the technology in that particular case.
Thank you. Personally, I've learned a lot, and thank you to Indian Arthroplasty Association, Mrinal, Ronen, and all the speakers. And Dominic, thank you for the support. It's been a great webinar learning for me, at least, and I hope those who've tuned in have learned. So on that note, thank you, everyone, and bye-bye. Until next time.
Thank you.